Hello, and welcome to the launch of the 2020 ANZ-Melbourne Institute Health Sector Report. My name is Richard Grayson, and I'm the Head of Health for ANZ's Commercial Bank, and I'll be your host for today. At ANZ, we're extremely proud to have the opportunity to once again work with the Melbourne Institute at Melbourne University to produce this report, which of course follows three prior pieces covering GPs, specialists, and the future of the medical workforce. All of these reports are available on the ANZ Health website if you just Google ANZ Health. I would like to note that ANZ has funded the research and collation of the data underpinning this report, but the author is independent and we've not provided any funding for the speakers today. Now, for those of you who are not familiar with ANZ Health, we're a specialist business within ANZ that comprises of over 100 bankers around Australia. ANZ Health services everyone from the individual medico to some of Australia's largest healthcare providers. As banking specialists, we strive to be more than just a bank. We aim to have deep and insightful relationships with our clients, as well as be an active participant in industry dialogue. And it would be fair to say that this ongoing impact of COVID-19 is certainly dominating dialogue at the moment, particularly with Victoria announcing 317 new cases today. So as such, this year's topic, which considers how doctors have responded to the pandemic and in what ways our frontline medical workforce has been supported, is very relevant. I would like to extend a warm welcome to each and every one of you. Let me also acknowledge the traditional custodians of the country throughout Australia and their connection to land, sea and community. We pay our respect to their elders, past and present, and we extend that respect to all Aboriginal and Torres Strait Islander peoples today. Shortly, I will pass across to Professor Anthony Scott, the lead author on the report, who will present to you for around 30 minutes. For those of you who are not familiar with Professor Scott, he leads the health program at the Melbourne Institute at the University of Melbourne. Following this, I will ask our panellist, Professor Michael Kidd, to comment and provide his insights. Professor Kidd may well be well known to many of you via his regular appearances in the media. Professor Kidd has been a general practitioner for 35 years and is a past president of the RACGP. He's currently Principal Medical Advisor and Deputy Chief Medical Officer at the Department of Health, as well as a Professor of Primary Care Reform at the Australian National University. Once Professor Kidd has concluded, we will open up for about 15 minutes of Q&A. To handle questions, we're relying on the Q&A function found at the bottom of your screen. You can submit questions at any time through this function. I would now like to pass across to Professor Anthony Scott. Thank you.
Thank you, Richard, for the introduction, and welcome everybody. It's great that you could be with us today. I want to first of all just say some thanks to ANZ, firstly, for funding this report. I'd like to also thank Associate Professor Matthew McGrail and Dr. Belinda O'Sullivan from University of Queensland, as well as Professor Grant Russell from Monash University for helping me put together the Mabel COVID-19 survey. I'd also like to thank Terence Bai, who cleaned and analysed the survey data for us, all the doctors who filled out the survey, most importantly, and then also Jess Delos, who's helped put all this together. COVID-19 has led to a number of significant changes to the healthcare sector, as well as all our lives. One of the main things is restrictions on elective surgery, which happened in May and are continuing in some states. Social distancing and staying at home. People are fearful of infection and therefore aren't visiting the doctor as much as we would like to. And then also increasing household financial pressure from the economic slowdown, which is also helping to reduce the affordability of private medical care. So those three things together are really impacting on the sector. I would like to, first of all, just tell you what we're going to do, what this report's generally about. We want to examine the impact of COVID-19 on GPs and non-GP specialists working in private practice. We want to look at workload and income, stress and mental health, and also changes to practice organisation. We've achieved this aim through the conduct of our Mabel COVID-19 short online survey. This is we're lucky to have the Medicine Australia Balancing Employment and Life survey, which has been running for 11 waves. We decided to send some emails out to doctors in May, between the 14th and 24th of May, which would be able to link back to some of the previous Mabel data. And in that time, we got responses from around 2,200 GPs and other specialists who previously completed the Mabel survey. And all of the data and the analysis to be presented have been weighted to ensure representativeness of the population of doctors in Australia. I'd like to start first of all with the impact on workload and working patterns. And this chart is from Medicare data, first of all, just to see the general aggregate trends. We can see towards the right hand of that graph, in March 2020, when the new telehealth item was introduced, that there was a significant fall, about 34% fall, I think, of level B face-to-face consultations, and a sharp increase in the number of telehealth consultations. And also at the top, we can see that actually overall activity increased rather than fell in that period. And that was because the number of telehealth consultations, of about 4.7 million in that month, was greater than the fall in the face-to-face of about 2.7 million. So there was a net increase overall. You can see that from April, between April and May, that there was some correction, that the number of telehealth items and face-to-face consultations flattened out, but there was an overall decrease in activity in that particular month. If we turn to the same chart for non-GP specialists, this is a bit different. First of all, we can see right at the end of the graph that there's more of a bounce back in activity in April to May. But certainly during March, when the telehealth items were reduced, there was an increase in telehealth use by these doctors as well. The purple line shows a fall in the number of operations, which again was due to the ban on non-urgent elective surgery. And the green line shows a fall in the number of face-to-face consultations. But for specialists, the increase in the fall in face-to-face consultations was much more than the increase in the number of telehealth consultations. Non-GP specialists were also able before this period to claim telehealth for mainly rural patients. And although that line looks quite flat at the bottom, the orange line, the number of those consultations increased by about 40% during March compared to February. So there's been a lot of change in activity. The COVID-19 survey also had direct questions about the impact on how the number of patients have changed. We can see that surgeons, anaesthetists, and other non-GP specialists have had more of a fall in the number of patients compared to GPs. Some GPs experienced falls in patients, some GPs experienced increases in the number of patients too. So there's a lot of heterogeneity in the response to the pandemic across doctors of different types and of different types of practice, which is important to highlight. One thing that we did find when drilling down a little bit into the data is that GPs in urban areas were more likely to report a fall in the number of patients for GPs compared to rural areas, and also that GPs in more affluent areas were more likely to report a fall in the number of patients. And we'll discuss this a little bit more later, but that might be to do with the kind of patients that live in affluent areas compared to more disadvantaged areas and how their use of healthcare has changed. I've mentioned telehealth already. This is delving a little bit more deeper into telehealth, where we can see again from the COVID survey how the increase in the use of telehealth differs across different types of doctor. So we can see that GPs are using it much more than non-GP specialists. GPs in the most disadvantaged areas are using it less compared to GPs in the most advantaged areas. Solo GPs are using it less than larger practices. Perhaps larger practices are better set up to do this. Or perhaps more solo GPs are located in less affluent areas. And also that we see that GPs in urban areas are slightly more likely to be using telehealth than those in rural. So there's a lot of, again, variation in the use of telehealth. Overall, 36% of all attendances in March and April were provided by telehealth. So that's a huge increase from a base of close to zero for GPs, certainly, and for specialists. But one of the issues is that pretty much all of that was telephone consultations and not video consultations. Specialists were more likely to use video consultations compared to GPs. They've been using telehealth before, so possibly more set up to do that. And for GPs, it may just be easier to do this. But also some patients, elderly patients, might not be able to have the facilities or capability to use video consultations and are happy just to pick up the phone. So again, that reflects a mixture of demand and supply side factors. Our survey also found, when asked, that 84% of doctors supported permanent Medicare funding of telehealth. And obviously there's a lot of support from patients as well. It's a more convenient way to contact your doctor. You don't have to take time off work to go to the GP. And in this time of precarious employment, it's probably good not to spend too much time away from your employer. So that's certainly benefiting patients as well. And also we found that 5% of doctors reported increased use of home monitoring for patients. And this home monitoring might be to monitor vital signs using digital technology and all other clinical indicators for people with chronic disease and who need regular monitoring, but again, can't get to the doctors because of COVID-19. So that's an interesting development as well. The impact on practice income and practice finances. We asked doctors about the impact on their monthly income from all the work they do as a doctor. And this reflects, again, a similar pattern to the numbers of patients, where we can see that surgeons and anaesthetists experience the largest fall in income. So 30% of surgeons and anaesthetists reported a fall in more than 50% in their income. And this was much higher than GPs and other specialists. And again, some GPs also experienced increases in income. And again, that just depends on their general mix of activity before COVID. One of the issues as well, again, in relation to this, is that similarly as before, GPs in urban areas and GPs in more affluent areas were more likely to report a fall in income. And again, we can explain this again by just the mix of billing and private billing before COVID. If we think, and we know from other research that we've done, that GPs and specialists in affluent areas are more likely to charge higher prices. So they charge rich patients more than poor patients. They're bulk billing less, whereas those in more deprived areas are probably bulk billing a much higher proportion of patients. So therefore, the move that we've seen from privately billed face-to-face consultations to bulk billed telehealth, including bulk billing incentives for face-to-face consultations as well, has meant that on average, revenue has fallen for these doctors who are more exposed to or who've previously charged higher prices and bulk bill less. So those types of doctors are going to be more affected, and that's what we've seen in this analysis. This is also reflected in this chart, which looks at the impact on income and practice finances. And GP and doctors are asked the question about describing the current financial position of your private practice, whether you're very financially stressed. And so again, we can see that there's significant amounts of financial stress for practices, but then again, there's still a decent proportion who still feel moderately comfortable financially. We can see that comparing GPs and non-GP specialists, that for those who are very and moderately stressed about their finances, although non-GP specialists experienced the largest fall in income, they were less stressed about it than GPs who experienced a smaller fall. So again, suggesting that that although GPs were less affected financially, it's had a bigger impact on stress for GPs than it has for specialists. And again, these levels of stress were more likely to be reported for GPs in urban areas. For GPs in smaller and larger practices, those GPs in the middle were less affected in medium practices. And for non-GP specialists, they were more likely to report high financial stress if the practice is larger. So again, there's some insights there about the different types of doctors that have been affected. In terms of impact on income and practice finances, again, this is a question asking about the likelihood that the practice would be sold or closed in the next 6 months. And so we can see that about 5% of GPs and 8% of non-GP specialists overall felt that the practice could be sold or closed. For GPs, it was more prevalent for those GPs in kind of medium 2 to 3 size practices with 2 to 3 doctors. For non-GP specialists, it was more prevalent in smaller practices. A lot more non-GP specialists are probably in solo practices than GPs. And also for non-GP specialists, we can see that the graph on the right just shows the distribution of this by age. Those more closer to retirement for non-GP specialists are more likely to think that the practice might be sold or closed, and that could be bringing forward some retirement decisions that were already in place. Impact on stress and mental health, and we know that health workers are at the front line, and so and this is a big issue anyway in terms of the health workforce. And certainly it's important to monitor this. So here we asked a question about stress, which is about being restless, feeling uneasy, unable to sleep at night, and around 61% of both types of doctor that we asked felt that they'd experienced stress more often than usual, with about 12% saying that experienced it about 12% more often than usual compared to the other doctors. We also saged in that table on the right that those who'd experienced a fall in income were more likely to report increased levels of stress than others. Now, we also asked questions about mental health using the Kessler K6, which is a short version of the Kessler K10, which is a clinically validated measure of mental health, and it's used to diagnose probable serious mental illness. We had the luxury here of being able to compare our respondents from the Mabel COVID survey with the previous Mabel survey, which was conducted in 2018-19. So we've got longitudinal measures, and this is longitudinal measures of the same people who answered both surveys. We can see the graph on the left that there has been a little bit of a change, particularly for those with less severe mental health problems. So, you know, on the left of the graph, we can see a slight fall in those who are in better mental health, and a slight increase for those who have kind of moderate mental health problems. But there's not much going on in the definition of probable serious mental illness. The K6 cutoff for that is that score of 19, and beyond that is defined as somebody probably having serious mental illness. On the right-hand side, we take that cutoff and just see the proportion of doctors who are above and below that cutoff with a serious mental illness. And though those numbers are quite small in percentage terms, there seems to be a bit of a difference for males. They're more likely to have experience probable serious mental illness compared to 2018-19. But those differences aren't statistically significant. But there is a general issue with males, and that could be because in this context, males are more likely to be practice owners than females, but there may be other reasons why that has changed over time. So that's something to consider as we go forward and people begin to adapt to the new COVID world. One of the key issues that we have and that have been reported in the media is about access to personal protective equipment for health workforce, and we can see that certainly that those who are more dissatisfied with access to personal protective equipment were more likely to be stressed, and that's particularly for non-GP specialists. So that's an issue that I think has largely been resolved, but with the national stockpile and various other things like that. But still, that was certainly an issue early on, and it's certainly an issue to watch out for as doctors try to protect their own health and the health of their families. Now, all of this has had an impact, and in order for doctors to continue practicing in private practice, a number of changes have been made to the way that they organise their practices. So you asked them about that. These can occur on the revenue side. So with a fall in demand, there's a fall in revenue, and they can replace that by applying for things like JobKeeper and that kind of thing. And they can also change the cost structure of the practice. So this chart just shows that around 50% of non-GP specialists applied for JobKeeper, compared to about 20% of GPs. Again, reflecting at least in that period in April to May, some of the issues in terms of the fall in demand. Other practices, other GPs and specialists reduced the hours of work for some practice staff. They improved practice management in terms of adapting to, using telehealth and not face-to-face. Encourage use of unpaid leave. A few report that no changes have been made, but then some people had to reduce the hours of staff, and some were able to keep paying them and some weren't. Some doctors reported deferring payment on business loans and taking on debt. A few laying off practice staff, and as we said, there's been an increase in home monitoring for some patients as well. So again, there's lots of heterogeneity. Practices have really changed the way that they've operated, and it'd be interesting to see how much of this continues or changes, particularly after any further changes to JobKeeper are announced, and also after any further changes to telehealth are announced as well. So one of the ways that practices can respond is to change their bulk billing and pricing in order to maintain revenue. But this is obviously largely in this sector with the introduction of telehealth, which was initially all bulk billed. There was then the introduction of the doubling of bulk billing incentives, which has driven the increase in bulk billing also for face-to-face consultations, which we can see in this figure. So again, this is from the Mabel COVID survey, comparing before and after, suggesting that the percent of patients bulk billed has increased for both GPs and non-GP specialists, but the average fees for GPs have remained about the same and similar for non-GP specialists. So again, we know that changes in fees and bulk billing influence access for patients as well. And certainly it's important to maintain access for patients who need healthcare but may otherwise think that they should delay a visit or not go at all. And there's been lots of examples of that. And it's important to be able to use these incentives to try to encourage people to continue to visit their doctors. So just want to conclude and discuss a few implications, which hopefully we can pick up on in the Q&A. I guess the first thing is that the COVID-19 seems to accelerated a number of pre-existing trends that we've already noted. The first is a move to virtual medical care through telehealth and other digital health technologies. We know that there is strong support. As mentioned, 84% of doctors in our COVID survey supported permanent funding of telehealth by Medicare. There's also been quality concerns. We know that there's been changes announced recently that telehealth should only be claimed through the patient's regular doctor. There's some definitions around that. There's issues about the high use of telephone consultations rather than video, which might have some quality concerns as well, and we yet to hear about that. But certainly, there is strong support from patients as well. It's clearly much more convenient for patients to go on video or pick up a phone. They don't have to spend time away from work, which is a bit important at the moment if people want to keep their jobs. And so that has very strong benefits to patients as well. So that's a thing that we're still waiting to see what's going to happen after September, but certainly it's an area that everybody's focused on. The second pre-existing trend that COVID has accelerated, we think, is the growing lack of affordability for private medical care. We know this before COVID with the fall in private health insurance, and also evidence of falls in the growth of private hospital care. And I think this has been accelerated now, and whether these levels of the use of private medical care will return to pre-COVID levels is doubtful, with continuing uncertainty, even though in the earlier graphs we saw that the number of operations and things like that have started to pick up again. That might be balanced against the fact that public hospitals, at least in Victoria, have been still asked to operate at only 75% of capacity, so that could shift other people back towards the private sector as well for hospital care. But it's something to watch, certainly, that will influence the future viability of the sector. So overall as well, we've seen significant instability and uncertainty, and that's probably going to continue as as the first wave and second wave continues, and we're going to have cycles of tightening and releasing of restrictions. We found again that GPs in urban and more affluent areas are most affected by some of these, that's really influenced by billing. We've seen the worst of fee-for-service. Most of the time doctors see the best of fee-for-service, but COVID is the worst, because if demand falls, then your income falls straight away. So we do need to think about, future ways to fund services which might smooth out that volatility in demand, and we're going to see that volatility in demand as things go forward. So how doctors react in terms of the billing and the amount of private billing and how much they charge is going to be interesting to monitor going forward. And one thing as well that really goes a bit under the radar, I guess in GP land in recent years, we've seen the growth of the corporate sector in primary care, but that's also happening for non-GP specialist private practices as well. If COVID does result in closure of practices, that will mean consolidation of these practices, and larger entities could also have implications for prices charged and bulk billing. The research that we're doing suggests that larger non-specialist practices charge higher prices. So again, that is an issue that we need to think of as well. So overall, the future does remain uncertain. There are issues around funding for telehealth and how that will pan out. There's issues about how the sector adapts to, I guess, continuing volatility in demand and uncertainty about what's going to happen with government restrictions, but also with how patients are actually changing the way they interact with the medical sector. But also within that, I think there's some new opportunities to improve efficiency and health outcomes for patients that we should be mindful of, particularly where we're looking at care that is needed and care that is most beneficial to patients, and how that will pan out will be interesting. So I'll stop there and thank you for listening.
Thank you, Anthony. That was really interesting. And I see we have a number of questions starting to come through the QA function. Just a reminder, we are relying upon the QA function to monitor questions. You can vote them up, so please do so as you get the opportunity. For now, I would like to pass across to Professor Michael Kidd for his views on the report and anything else that he might like to share with us. Michael.
Great, thank you very much. Thank you, Richard, and thank you to Tony and all your team at the University of Melbourne for the report. My declarations: I'm a graduate of the University of Melbourne Medical School, and I'm privileged to be an honorary professor with the Department of General Practice at the University of Melbourne, so very pleased to be able to join you today. The comments I'm going to provide, I'm providing as an individual. I'm not here speaking on behalf of the Australian Government or the Commonwealth Department of Health, and I do need to say that I have received no support from ANZ. I'd also like to thank all our peers who've taken part in this survey. As Tony mentioned at the start, 2,235 of our peers have given of their time to contribute their insights and their experiences about what's been happening in their practices and their lives during the pandemic to date. And so thank you to everybody who has made that contribution. I know people are incredibly busy with their clinical responsibilities and the other things which they're doing, but it is really very valuable to us to get your insights into what's happening in research like this, so that we can inform ongoing planning and ongoing policy development. I want to also commend Tony and the team on the report. There's some really great insights in the report, and I encourage all of you to read it in full. Lots of further details about people's clinical activity during the pandemic, about the financial stresses that we've seen on our practices, about the mental health and stress that many of us have been under during the pandemic to date, and issues about access to personal protective equipment. I did want to provide some comments, and do so in the context of the 5 principles which are underpinning Australia's national COVID-19 primary care response, because I think that this report actually touches on all of the 5 principles. The first principle is recognising that general practice looks after the people who are most vulnerable to COVID-19, because of course in general practice we look after everybody in the community. With COVID-19, obviously we're most concerned about elderly people, especially people aged over 70 years, about people with chronic healthcare concerns, people who may be immune compromised, Aboriginal and Torres Strait Islander people, and others. And of course, these are people who are being looked after with their medical care by GPs right across the country. And so therefore, it's been really important with our national response to recognise that the people most at risk of COVID-19 are the people being cared for through general practice. The second principle is about providing treatment and support services to people diagnosed with COVID-19. And again, this is happening largely through general practice. As we know, the majority of people with COVID-19 do not end up being hospitalised. Many people have mild symptoms, others have much more significant symptoms but don't result in them needing to be in hospital. And very important, these people are being cared for by their GPs. And of course, we're able to do this, especially in the areas under lockdown, as much of Melbourne and surrounding areas in Victoria are at this time. We're able to do this using telehealth, and Tony has shown us, particularly during when we had the national lockdown, about the rise in the use of telehealth and the proportionate decline in face-to-face consultations at that time. I do also want to provide a shout out to our colleagues who are running the GP-led respiratory clinics right around the country. We now have over 140 of these clinics, which don't just do testing, but they also assess the respiratory symptoms that people are presenting with, recognising that often respiratory symptoms won't be due to COVID-19, they may be due to something else. And the GP-led clinics have enabled GPs to be seeing people with respiratory symptoms away from regular general practices, and so therefore reducing the risk of transmission to patients presenting to general practice with other concerns. The third principle is the importance of continuing the regular healthcare services for the whole population, being provided by GPs and by other specialists, as we've seen in Tony's report. And we do know from past epidemics and past pandemics that sometimes we see more morbidity and mortality related to people delaying or not seeking health advice for other medical problems than we do from the infectious agent. And we certainly don't want to see those sort of outcomes occurring in Australia. It's really important that people are still attending their general practice for the development of for new symptoms, for their assessment, for the management of their chronic health conditions, for the management of their mental health conditions, and of course that we continue the preventive measures, childhood immunisation, cancer screening, and others, which take place all the time and which need to continue even when we're living through a pandemic as we are at the moment. And of course, this means that we need for our practices to remain financially viable. And the Australian government, both through the initiation of the telehealth item numbers under the MBS, which currently run to the end of September, and also with the additional practice incentive payments to support the viability of practices during a time when we have seen, at least in some practices, a downturn in the number of patients who are being seen. The fourth really important principle is about ensuring that people working in community health settings have access to the same levels of protection as people working in hospitals. Unfortunately, in past epidemics and pandemics in other parts of the world, we've seen masks and other PPE being provided to people working in hospitals and not being provided to people working in general practice or in other community-based healthcare settings. Of course, as we've seen with the community transmission in Melbourne, it's absolutely essential that every healthcare worker, wherever they're working in areas of significant community transmission, has access to personal protective equipment to protect both themselves, but also to protect their patients. And this, of course, also applies to the work that many GPs are doing, supporting elderly people either in their homes or in residential aged care facilities, again, looking after the most vulnerable. And the fifth principle is about mental health and recognising that during a pandemic, we need to be paying attention to the mental health needs of our patients, but also of our healthcare workforce. And again, Tony's survey has looked at the impact of the pandemic and the stresses associated with this on the mental health and well-being of doctors and other healthcare workers during the pandemic. And we've seen there is a significant impact. And a reminder to all of those of you who are online that there are specific resources available to support healthcare workers who are feeling anxious or fearful or depressed or despondent, available through the Black Dog Institute, through Beyond Blue, and through other mental health supports. So there's not only supports available to our patients, there's also specific supports available to all of us as well. So Tony, I think your report touches on all of those areas in the 5 principles underlying our national primary care response, and provides additional richness to the feedback which we've been receiving and to other research which has been carried out around the country to date during the pandemic. So thank you for what you've done, and thank you for this report.
Thank you very much for that, Michael. We might now move to Q&A. So once again, just a reminder, Q&A can be accessed through the Q&A button on your screen. And if I could encourage everyone to please vote up any questions that they would like to start with. Now, I think perhaps the first one, which I might throw to you first, Michael, and then perhaps Tony afterwards. Are there any studies that suggest if there are differences in the quality of care via telehealth versus face-to-face?
Thanks for that, Richard, and thanks to Abigail, I think, who's put that question forward. So look, we have a lot of research on telehealth in clinical medicine. Telehealth was not discovered in February of 2020 in response to the COVID-19 pandemic. We've been using telehealth for a long time, both in Australia and around the world. And what we know from the research is that there are some things which telehealth does very, very well. And there are some things where you absolutely need a face-to-face consultation with a healthcare provider. And of course, there are other things where we can use a blend of telehealth and face-to-face services. This is one of the reasons behind the Australian government's decision as of next week to only allow the use of the MBS telehealth item numbers in general practice for when patients are consulting with a general practitioner who has already provided them with face-to-face care in the previous 12 months, or with a doctor from a practice where they've attended in the previous 12 months. Although I have to say that change is not being brought in at this time in the lockdown areas in Melbourne or the surrounding areas, but it is being brought in across the rest of the country. And that's because we know the importance of continuity of care. And we know that the telehealth works well when it's being utilised with the doctor who actually knows the patient or has access to the history of the patient who is seeking care.
Thank you. Tony, is there anything that you would like to add?
No, not really. I think it is important to, now that we have a much higher use of telehealth than we ever have before in Australia, to start some new research into that. It's a perfect time to be able to look at the uptake and do some data collection on quality and patient outcomes. So it's important to start that.
Okay. Thank you. Tony, might just keep it with you. There's a couple of questions here which are looking to get into a little bit of the detail of the data. So I might bundle a couple of themes that are coming through, if that's okay.
Yeah.
So first of all, could you perhaps speak a little more about the possible reasons for GPs in urban and more affluent areas being more affected? And also another common theme is there's a lot of interest in the gender differential in your data. Could you perhaps also talk to that as well?
Yeah.
Thank you.
So I think the GPs in urban and GPs in affluent areas, I think that is an interesting thing. And as I said, I think there is evidence that GPs in more affluent areas charge more, you charge richer patients more, bulk bill less. And so they are more at risk of a sudden fall in income, combined with the type of populations that you have there, who could be more risk averse in those areas compared to other areas, and more likely to experience a fall in patient numbers as well. Then that's a bit of a double whammy to those doctors in those particular areas. But that means that, doctors in more disadvantaged areas and rural areas have been less affected, although there is a lot of variation in the data that we see. So it's hard to, make a statement about the average what's happened, because there is a lot of variation. But I think that just depends on a mix of billing and services and type of population that each doctor sees or saw before this happened. In terms of the gender differences, we have cut most of the data by gender, and I think that is a particular issue. We found some things, but not others. We found that actually, it's in the report but not in the presentation, that in terms of hours worked, for example, that men were more likely to reduce their hours worked, and female doctors actually hours worked didn't change or even increased. So how that pans out in relation to the changes in the number of patients and changes in income, and also the fact that, as I said, men are more likely to be owning the practice than women, so they may have been affected worse in this particular setting of private practices, which we've looked at. One thing we didn't, we have collected some data on public hospital specialists as well. We didn't include that explicitly in this report, but the analysis that we have done on that data suggests it's very similar to non-GP specialists in general.
Okay, thank you. Maybe this is probably one for both of you. It has got a number of votes here. It's quite a long question, which I might just seek to paraphrase. goes. But I think the heart of it is that, obviously doctors are experiencing a significant level of stress due to the COVID crisis. The question is, do you see any danger for self-medication or any kind of other outcome, whether it be alcohol abuse or anything like that? And is there anything that needs to be done to support GPs? What do you think additional that needs to be done to support GPs through this period? Perhaps, Michael, could I throw to you for that one first, and then maybe, Tony, we can get your thoughts afterwards?
Yeah, thanks, Richard. So just on the previous question, and it does touch to this as well, we asked Australian healthcare to change the model of care delivery almost overnight in response to the pandemic. And of course, we saw this with moving to telehealth. We had anticipated that we'd transition to telehealth over a 10-year period. We did it in 10 days because of the necessity to protect the most vulnerable people in our society, to protect our vulnerable colleagues and allow them to be delivering telehealth, and then move it out to the whole population as the nation went into lockdown. And of course, now we're back in lockdown in the Melbourne area. And so huge stresses related to changing the model of care. This, of course, was acknowledged, but also acknowledging the huge stresses on the general population. We saw many of our patients who lost their employment, many people who now are on the job seeker and job keeper payments, many businesses which have suffered very severe financial stress and may not be able to continue opening. The Australian government, as I said, provided additional practice incentive payments to support general practices, and doubled the bulk bill incentive for consultations with under 16-year-olds, people on concession cards, and people who are vulnerable to COVID-19. So this has been a very stressful time. And of course, it's also stressful for us as healthcare practitioners when we are dealing with the increased stress and distress in our patients. And the figures that Tony showed us, of course, apply to the general population as well. I think the entire world has been anxious over recent months. I think many people have had great difficulty sleeping properly. Many people are very worried about their older loved ones. Many people are in isolation and are not able to travel and be with their family members. All these things apply to us as doctors, just as they apply to the rest of the population. And the risk is, we know there are increased risks for doctors to engage in self-medication. We know there are also increased risks of self-harm among doctors and other healthcare professionals. And that's why these specific mental health resources have been developed by Black Dog. It's why the additional resourcing has been provided to Beyond Blue and to other mental health service providers, recognising the needs that we have. And so the message really to all our colleagues who are online and to all your friends who are working in healthcare, if you are feeling that things are getting on top of you and you need to reach out for help and support, please do so.
And yeah, just to briefly add to that, I think it is a worrying issue, but also I think there's evidence that a lot of doctors don't have their own GP either, and that's a big issue, that doctors, they're pretty resilient folk on average, but don't necessarily look after themselves as much as they would look after their patients, for example. So that is a big issue that's important for doctors out there to get a regular GP.
Okay, thank you, Tony, and thank you, Michael. There's another question here, Tony, which goes a little bit to the data. Is there a particular reason why patient numbers, not just income, would have fallen in the most affluent areas as the results suggest? And I think that the particularly interesting is the second component to it, which I know you have an interest in, is does this point to a particular patient group missing out on care? Now that's obviously a theme that is kind of has come through in a number of other research, that people are actually kind of holding back visiting the doctor. Could you perhaps talk to that, and then I might throw to Michael for his views as well?
Yeah, I think, look, I think with healthcare, there are, things that you really need to go to see your doctor for, and things which, well, can wait a bit or not. And those delays are important. But nevertheless, often as an individual, you don't know whether what you got is important or not, or whether you need to get something done about it. So those attitudes will play out in this. There may be people who are delaying healthcare because what they were going to go for was actually not very important, and in reality it might not be very important. But there's other people who might think it's not important when it is important. So that's something that is influencing demand, and it may be people in affluent areas have different views of that compared to people in more disadvantaged areas. You may characterize people in affluent areas as the worried well, and so it might be that things that they normally go for the doctor for, they won't bother, and it doesn't really affect them at all. But for other patients it will, and that's the thing. It's trying to really get a grip on who's not going, who really should, and that's a tough one.
Michael, do you have anything to add to that?
Yeah, certainly. So, we're very concerned about people delaying seeking care. We're very concerned during the initial lockdown that we know many people who had appointments for the management of chronic conditions postponed those appointments. We know that there were people who developed new symptoms and just thought, I'll wait, and didn't reach out. One of the things that we put into the telehealth measures was the ability for GPs to reach out to their own patients rather than have to wait for the patients to reach out to the GP. So allowing GPs to reach out to their frail elderly patients who may be at home on their own, to their patients with disability, to their patients who are receiving chronic disease management, to people with mental health concerns, particularly those who we knew were living on their own. We then, after the initial lockdowns were lifted, we had a lot of activity with people catching up, people presenting to their GP with the list of problems which had arisen during the previous couple of months. Just as we're starting to catch up there and starting to get people to have the referrals and the investigations and so forth that they need, we now have the additional lockdown occurring in Melbourne and surrounds. And so the additional delay for many people in getting the care that they need. So again, for those of you who are practicing in Melbourne, please continue to be reaching out to your most vulnerable patients, the people you would have been expecting to see in your practice over the next few days. And also, of course, with the rising number of people with COVID-19 amongst our patient populations, please be reaching out to those people as well as soon as you hear that they have been diagnosed with COVID-19, and following them through telehealth and providing them with assistance and support. This is a new way of practicing for all of us, but the contributions that we're making to the health and well-being of the people of our nation during this national emergency should not be underestimated. These are extraordinary contributions.
Tony, is there anything you'd like to add there?
Well, one of the issues, I think, with respect to private medical care, particularly hospital medical care, which is being avoided perhaps, is that the issue of low value care, that things like, knee arthroscopies and other things like that, if you didn't do them, it's not actually going to affect people's health very much if you don't do them. Going to a physio is just as effective as having a knee arthroscopy for some things. So in terms of the amount of care that is low value, the fact that people aren't going to the private hospitals doesn't necessarily mean that public hospitals are going to get swamped by these patients. It depends on how much low value care is being stopped, and therefore would make no difference. So, but saying that, there is still issues of care that is needed, which we don't know about, and these things are hard to monitor.
Sure.
It is an important issue as well that you've raised, Tony, which is the other healthcare providers that people are seeing. And of course, we've seen delays again in people going to their regular appointments for physiotherapy, to the dentist, to the optometrist, to many of the allied health providers that people would normally be seeing who needed to close down or restrict their services at the times of lockdown. Of course, the telehealth is available to those people who've been receiving care under chronic disease management plans from allied health providers or under mental health plans from psychologists and others, and this can continue using telehealth.
Thank you. Okay, we just have a couple of minutes left, so I might just ask one final question, which again is a bit of a combination of a couple we've got at the top here. So it really goes to, are there any plans to assess outcomes of the delivery of new methods, so in particular telehealth, to better guide the delivery of healthcare in the future? Michael, perhaps would you like to start with that one?
Yes, so certainly with the role that I have with the Commonwealth and being involved with the telehealth initiatives, I'm aware that there are a number of research groups around the country which are looking at telehealth and just different aspects of its use, looking at what may have been the benefits, but also some of the shortcomings, as we discussed at the start, when face-to-face consultations are required, ways in which telehealth may be used in the future, examining some of the things that Tony has identified to see whether the entire population has been benefiting from telehealth, or whether there have been any disadvantaged groups in particular which have been missing out. Clearly, we're concerned about people who may not have the capacity to do video consultations, who rely on the telephone. We're concerned about people living in rural and remote areas, what impact this widespread telehealth has had, whether it's actually boosted the opportunities to reduce some of the geographic barriers for some of our patients and for many, many others. So, yep, there's a lot of research underway, and I think we're going to need a lot more as this continues to roll out over the future.
Anything you'd like to briefly add there, Tony?
Yeah, there's a lot to be done, and hopefully the MRFF will do something in the future.
Excellent. Well, thank you, Anthony and Michael. Unfortunately, we are now out of time. There are a number of questions left at the end here, which we haven't got to. We may well see what we can do in getting back to people on those. Anthony, we can take that off offline. But certainly, on behalf of ANZ Health and the Melbourne Institute, I'd like to thank you all for your attendance. I do hope you've enjoyed the event. Access to the report will shortly be provided via a link in the chat function. We will also distribute the report and the video of this session to all registered attendees in the coming days, as well as loading both on the ANZ Health website. Of course, if you are in the health industry, would like to discuss any industry trends or any banking needs, please feel free to contact me directly. My email address is richard_grayson@anz.com. My mobile is 0401 693 718. And also, just very quickly before we do close, a special thank you to those which have worked really, really hard behind the scenes to make this event happen. So, in particular, Glenn Fisher at ANZ, thank you, Glenn, and Jess DeLon at the University of Melbourne. Thank you very much, Jess. That does conclude today's session. Thank you all very much for joining us. Hopefully, we'll see you all soon. Stay safe.
Thanks, everybody.
Thank you.
Bye.